So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline-concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV.
So here's the way that we actually diagnose HIV since 2014. So we have these immunoassays that's a combination of, well, first of all, it's both HIV 1 and 2, and then it's a combination of antigen and antibody. And it has a extremely high sensitivity and specificity. So because of these high numbers, if someone is negative or positive, you don't really need to confirm it. So if someone is positive, they are likely to have HIV. There's no need to confirm. And then if they don't, if it's negative, if they haven't had any risky behavior, in the past 20 days or so, then they're unlikely to have HIV. But if somebody had for example, unprotected sex like 5 days ago and this test is negative, that doesn't really mean they don't have HIV, because there hasn't been enough time for the antigen or the antibody to build up for this assay to detect it. But after 10 to 20 days, then if it's negative, you can actually rule out HIV infection. Now, once it's positive, they are likely to have, extremely likely. There's only a 1% chance that this might be a false positive. But if it's if it's positive, they're extremely likely to have HIV. The question is, do they have HIV 1 or 2? So what you do next, these are not really to confirm, but rather to differentiate. So you do a HIV 1 and HIV 2 differentiation assay to figure out whether it's HIV 1 or HIV 2. And the reason that, so these are fourth generation immunoassays that we have. Lately, there's been fifth generation assays that actually combine differentiation and antigen antibody tests in the same test. So it will actually tell you day one. If it's positive, it will tell you if it's HIV 1 or HIV 2. But those fifth generations assays are not readily available everywhere. But this format in this algorithm is actually available in most places. So just keep that in mind. So the problem is, if the differentiation test actually tests negative for both, and you actually test a positive, you can have two options. So either that was a false positive, or this test wasn't able to actually pick up which HIV the patient has. Which brings us to the more expensive test. So we actually have the nucleic acid test. So this is basically PCR. So they do PCR, and the problem is we only have PCR for HIV 1. So if you didn't know if it was positive and you couldn't tell if from the differentiation test if it was HIV 1 or 2, and if you do nucleic acid test and if it's negative, then you know for sure it's not HIV 1. But then you have two options. It's either HIV 2 or it was a false positive. We just don't know because this PCR doesn't detect HIV 2. So that patient will require specialized testing to figure out if it's HIV 2. Now, if they do PCR and it's HIV-1, then you know for sure it's HIV-1. Now, this is the usual algorithm. So if it was, because so these tests are, less expensive than a PCR. But if you were in a hospital and if the hospital actually performed this PCR to begin with, then there's no need for the antigen antibody and the differentiation test, because this actually detected the RNA itself. So and here's so you know from the exposure, it typically takes 10 to 20 days for these RNA levels to go up, and also along with the P24 antigen. So that's why if most of the fourth generation assays that we use, it detects it between 10 to 20 days. So if somebody hasn't had risky behavior before the 10 to 20 days, then you can, and if this doesn't detect anything, then we can be confident that they don't have HIV. So historically, because we had some of the challenges with HIV treatment was that, but first of all, the drugs were very toxic. So terrible side effects, which is a problem if if it affects the adherence of patients. And the second problem was that drugs weren't readily available. So the question was, when exactly should you start treatment? So historically, treatment was started if the patient's CD4 count was too low. So typically if it was less than 500, they would start treatment. If it was greater than 500, people would actually delay treatment. So what the START study did, which was published in 2015, was that they actually enrolled patients with CD4 count of greater than 500, and they said, what if we actually treat them? We're not going to wait till their CD4 count is low. We're just going to treat them. And we also will test what the standard of care was. So the other group, we actually defer until their CD4 count is less than 350, and then we'll give them treatment to see if it makes a difference if we start immediately or wait till the CD4 count is less than 350 to start treatment. And they were looking at the primary composite endpoint of serious AIDS or death from AIDS, and also serious non-AIDS events and death not attributable to AIDS, such as cardiovascular disease, end-stage renal disease, decompensated liver disease, and non-AIDS defining cancers. And what they found was that the group that actually started immediately, there was a huge difference as far as those primary endpoints. So they actually had to terminate the study because there was a huge benefit to starting treatment immediately. In fact, when you look at the hazard ratio of 0.43, there was a 57% reduction in risk of all those endpoints. So since that study was published, here's the DHHS recommendation. So the panel actually recommends ART for all HIV-infected individuals to reduce morbidity and mortality. And morbidity and mortality is talking about those endpoints that I just mentioned. And previously they had a strong, so you can see the rating of recommendation and rating of evidence. This is A1. So it previously was A1 for less than 350. But ever since that study, they actually expanded to every group of CD. In other words, regardless of CD4 count, ART should be initiated in patients. So it doesn't matter what their CD4 count is. And of course, previously, even if somebody's CD4 count was greater than 350 or greater than 500, it was still recommended in order to prevent transmission. So, for example, if they had serodiscordant couples, and so if one partner had HIV and the other couple did not, then you would give ART to the couple that the partner that had HIV in order to prevent transmission. So regardless, everybody should get treatment, for reduction of morbidity, mortality, and transmission. Now, when it comes to pregnancy, of course, this is a different guideline now. So DHHS has a separate guideline for pregnancy. So they say that all pregnant patients should be initiated as early as pregnancy, as early in pregnancy as possible, to make sure that that there's no vertical transmission. And in order to prevent vertical transmission, it's important to maintain undetectable viral levels before before delivery, during delivery, and even after during in the baby. Now, if the mother happens to have detectable levels, it's recommended to check for drug resistance. However, they recommend not to wait for the results of those those resistance tests. They say to go ahead and start treatment until and just wait for the results to come back. And then once the results come back and they were started on something that wasn't working, just switch it to something that was susceptible. Now, here are the treatment goals. So because interruption of treatment can actually result to rebound viremia, because what we're really doing is we're suppressing the virus. So as soon as you stop treatment, the viral levels will actually go up. So we can't really cure HIV. We're just suppressing it. So the goal of treatment is to be able to actually suppress, be able to sustain the suppression of the RNA levels in the patient. The other thing that we want to do, we want to restore and preserve immunologic function. So they're talking about CD4 count. We want to bring it back to normal, or at least increase it as much as possible. Of course, we want to reduce morbidity and mortality and improve quality of life. And of course, prevent HIV transmission. And because our current treatments are, quite effective, once ART is initiated, is expected to have undetectable levels 12 to 24 weeks after 12 to 24 weeks of treatment. And then of course after 12 to 24 weeks, the viral levels should become undetectable, but you continue treatment indefinitely to maintain that undetectable level. So when it comes to the treatment of HIV, here's the general rule. So you actually, in the regimen, you never want to use monotherapy because the virus is very good at becoming resistant. So because the virus is very good at becoming resistant, you always want multiple combinations. You do not use monotherapy. And of course, the only time you would use monotherapy is, if the virus is resistant to a lot of available options and only one thing is left, and at that point you will have no choice but to use monotherapy because that's the only thing left, which is not very common. But starting someone who's never been treated before, you never do monotherapy. So the general rule is that you need a backbone plus a third agent. And the backbone is you use two nucleotide reverse transcriptase inhibitors as a backbone. So we have three available combinations for the backbone. So you can see each of these pills has two nucleotide reverse transcriptase inhibitors as part of the backbone. So these are just examples of backbones. So don't use any of these alone. You need a third agent added to this, which I will talk about in a little bit. So these nucleotide reverse transcriptase, which we just call them nukes. So you need two nukes plus a third agent. So you can see like Truvada has two nukes in it. So emtricitabine and tenofovir are two nukes. So these two nukes, Lamivudine and abacavir, which come as a single tablet. note that pretty much with the exception of abacavir, all nukes are renally clear, so you should always look for you know recommendation for renal adjustment or contraindication. Abacavir is actually hepatically clear, so it doesn't have renal adjustment, but because it's combined with you can never use abacavir alone. It has to be combined with another nuke, so it turns out so it will always have that the creatinine clearance adjustment, just because it will always come with another nuke. One thing that's specific to abacavir is that before starting someone, you actually have to get a HLA-B5701 testing, and if it's positive, the patient should not receive abacavir because they will be more likely to have severe or even fatal hypersensitivity reaction to this drug. So it is important to order HLA-B5701 polymorphism testing before actually starting abacavir. That's extremely important. It's a black box warning. The other thing that's specific to abacavir, it actually doesn't have activity against hepatitis B, whereas lamivudine, tenofovir, and emtricitabine, they all have activity against hepatitis B. Now, when it comes to tenofovir, there are two different types of tenofovir. It's basically the salt for the formulations are different. So there's a TDF and there's TAF. TAF, of course, is the most recent one that was approved in 2015. When it comes to the adverse effects, note that the TDF, tenofovir disoproxil fumarate, can cause nephrotoxicity as well as bone mineral loss. So because of bone toxicity and nephrotoxicity, that's something to keep in mind with any regimen that includes TDF. So how is TAF different than TDF? So tenofovir is the actual drug. Tenofovir, which is an analog of adenine. So let's say this is the GI tract. So let's say the patient takes an oral tablet. Tenofovir is taken orally, so it's in the GI tract. The problem is tenofovir is not absorbed on its own. So if the patient takes it orally, none of it is absorbed, none of it comes to the plasma. So what they did is that they combined tenofovir with disoproxil fumarate, so it actually improved absorption. So TDF, when the patient takes it orally, it can actually be absorbed. So then the actual drug comes into the plasma. Now, one thing about this formulation is that once TDF is absorbed, a small portion of it goes into the T cell. So this is the T cell where the HIV actually replicates. The rest of it stays in the blood. And the HIV is not really replicating in the blood. It needs to go inside the T cell and then replicate. So a small portion of tenofovir will go inside the T cell and will actually block HIV cycle. The problem is the majority of it stays in the blood, so it will go to the kidneys and it will cause nephrotoxicity. It will go to the bones and it will cause bone toxicity. So what they did is that they actually came up with a new one. They said if we have tenofovir alafenamide, and look at the dose differences. So TDF was 300 milligram and TAF is only 25 milligrams. So they're using a significantly smaller dose of the drug, which will actually help tenofovir be absorbed. So once they take TAF orally, it will be absorbed. Now, most of TAF will actually go inside the T cell, and a small portion of it will stay in the blood. So even though they used a significantly smaller dose, what happened was that they actually ended up with the same concentration of tenofovir in the CD4 cell. So it does the same job. So it will interrupt the cell cycle, and a very small portion of it will stay in the blood. So because a small portion of it stays in the blood, it is less likely to cause nephrotoxicity and less likely to cause bone toxicity. That's the primary difference between TDF and TAF. Both of them are made by the same manufacturer, so what's really happening is as time goes on, TAF is replacing all the formulation with TDF.
Alright, so which regimens should we initiate? Here are the recommendations from DHHS guidelines. So the top section are combinations that include integrase inhibitors. The next section has protease inhibitors, and the third one has non-nukes. Generally speaking, the recommended regimens for most HIV patients include anything that has integrase inhibitors. Now, the one with elvitegravir used to be, and by used to be, I'm talking about just a few months ago, prior to December of, or I should say prior to October of 2018, was also recommended for everyone, but they actually downgraded it to an alternative, so it's recommended in select situations. So anything that's yellow is an alternative, meaning it's only recommended in selected patients, whereas the green ones are recommended for most patients. So the reason elvitegravir is no longer recommended for most patients is because of cobicistat, which causes a lot of drug interactions. Now, the regimens that have a plus sign, that means it's more than one pill. The ones that are just a slash, that means that's a single tablet regimen. Now, for pregnant patients specifically, the green ones are what's preferred. Now, the general rule is that you need at least two nukes as a backbone plus a third agent. So your two nukes would be one of these over here. So either emtricitabine plus tenofovir, or lamivudine plus abacavir, or lamivudine plus TDF, and then you add a third agent to it. So you choose one of these three, and then you add a third agent, so either a protease inhibitor or an integrase inhibitor. Now, with dolutegravir specifically, you should only use it in second or third trimester. It is not recommended to use in first trimester because there's been reports of neural tube defect. So it should not be used. In fact, even patients who are at childbearing age, they should get the pregnancy test and make sure that they are not planning to get, but first of all, to make sure they're not pregnant, and also to make sure that they are taking, they're getting education on receiving birth control before they can get dolutegravir. Elvitegravir is not recommended because the volume of distribution is different in pregnant patients, and they will not have enough concentration of elvitegravir and cobicistat. So both elvitegravir and cobicistat, so anything that needs cobicistat boosting is not recommended in pregnancy.